right. Good afternoon, everyone, and welcome to the first of our concurrent sessions. Thank you. This is session number 3, the session on the MyCog program. So what we'll do today is I'll introduce each of our speakers as they come up. They will each give a brief presentation, and then at the end, we'll have time for a question and answer period altogether. All right, so our first speaker today is Laura Curtis from Northwestern University, and she'll be talking today about barriers and facilitators with implementing MyCog into primary care for the early detection of cognitive impairment and dementia. Lessons from the Toolbox Detect trial. Thank you. Thank you for the introduction. So I have no relevant financial disclosures. And first, I just want to acknowledge the team, many who are sitting here and in the audience. Okay, so early detection of cognitive impairment is imperative. It helps to identify potential treatable underlying conditions and provide support services when impairment is due to progressive conditions. However, primary care settings are ideal for identifying CI, given clinicians' familiarity with the patient and the regular contact to monitor changes over time. However, cognitive impairment frequently goes undetected in primary care. In a 2017 meta-analysis of 23 studies by Wang and colleagues, over 60% of ambulatory care patients in the U.S. with MCI or dementia is not detected. So the Toolbox Detect trial was designed to widely implement and evaluate a user-centered, scalable electronic health record-linked strategy for the routine detection of cognitive decline among diverse primary care settings. This was in response to the low-cost detection of cognitive decline in clinical settings RFA. And in that, it included a call to facilitate the integration of assessments into existing healthcare settings, particularly for cognitive testing requirement for Medicare annual wellness visits. So this fit well into the primary care paradigm Dr. Wolf showed in his talk this morning. This looks familiar. So the Toolbox Detect paradigm follows this lower path here. So in patients who are 65 and older being seen for an annual wellness visit, they automatically get the MyCog assessment. Then if the assessment indicates impairment, a standard protocol for clinical action. And I'll get into some more details about this as I go on. So the MyCog assessment contains the MyCog assessment is iPad-based, as you know already, but and contains self-administered adapted versions of the dimensional change card sort and the picture sequence memory from the NIH Toolbox version 2. So adaptations we made were both to make them self-administered, to reduce the picture sequence memory from 2 trials to 1 to shorten it, and then we also added new stimuli to make it different and reduced the number of pictures from 15 to 12. So we worked closely with the Northwestern University Tech team and the Northwestern Medicine EPIC team to be able to integrate this into clinic workflow. The MyCog app was designed to run the assessment, but also to score and interpret it in the MyCog app. The assessment is activated by a barcode that's unique to each patient, which automatically shows up when they are scheduled for an annual wellness visit. It is typically scanned by the medical assistant when rooming using the iPad, and then it's handed to the patients to self-administer. Once completed, the results automatically populate into the chart, and then if they are impaired, the physicians receive a best practice advisory with a smart set that facilitates next steps for evaluation. And this includes the ability to order labs, further testing, referrals, as well as other resources to share with the patient and their families. So the main objectives of the Toolbox trial were to evaluate the effectiveness of the MyCog paradigm compared to enhanced usual care to promote timely detection of cognitive decline and subsequent care management, and also to investigate the fidelity and identify any patient, caregiver, or health care provider or system barriers to its optimal implementation. So it is a practice randomized pragmatic trial where primary care clinics are randomized to Toolbox Detect or usual care. We plan to enroll 40 clinics throughout Northwestern medicine healthcare system. At the end of the trial, we will be comparing the rates of detected and/or diagnosed cognitive impairment and rates of cognitive testing by arm. And that would be using data from Northwestern Medicine's electronic data warehouse. So since the trial is still active, this presentation focuses on the fidelity of Toolbox Detect and feedback from primary care clinicians, practice managers, and medical assistants, both regarding participation in the trial and for its continued use. So currently we have 30 practices enrolled, 15 in each arm, over 17,000 patients with annual wellness visits occurring in the participating clinics. After a few months of piloting in one clinic, more clinics were added in early 2023, and we've been enrolling at a consistent pace since. MyCog has been completed in 72% of the annual wellness visits, and the completion rates vary widely by clinicians, from 38% to 90%, and I'll get into some potential reasons for this. So in terms of facilitators, the use of an iPad was intriguing for many clinicians, and they thought of different ways that they could also use the iPads to help their workflow. The MAs liked the seamless automation of cognitive testing data collection without the need to administer the tests themselves and then enter the results into the chart, as they were currently doing with pencil and paper tests. So being able to scan the barcode and handing it to the patient to complete themselves would allow them to complete other tasks during that time, making the visits more efficient. Clinicians were also interested in a more rigorous test and the potential to reduce false positives. It's important to note that in creating cutoffs for cognitive impairment, we favored specificity over sensitivity based on early work where clinicians indicated that false positives would be more detrimental to patients than missing impairment before the following year. In cases where cognitive impairment was found, the inclusion of explicit clinical decision support was highly valued. So while technology use is increasing dramatically in older adults, some are still less comfortable using technology if they aren't as experienced. This caused few patients to refuse, and for others, it took the MA just a little more time to help orient them to the iPad. However, once they began the assessment, people were able to complete it without any problem. So the time to complete the assessment can also vary greatly. While the average of 10 minutes is acceptable to most clinicians, those who take longer may not finish by the time the physician comes to the room, and that would disrupt workflow at times. The clinicians also use the EHR quite differently. Our paradigm was added to the standard recommended annual wellness visit template, but not everyone uses it. So while the results are still available if they didn't use that template, we needed to create a workaround and to train them on how to find it. And since it wasn't as straightforward, it could potentially affect use. So based on these facilitators and barriers, adoption and use has been variable. Both patient and practice level barriers contribute to this variability. It's not a one-size-all-fits approach, even within clinics, and it allows for a more tailored workflow to optimize screening in clinical settings. Thank you.
Right, thank you. Our next speaker is Morgan Bonham from Northwestern University, and she'll be talking with us today about primary care detection of cognitive impairment, leveraging health and consumer technologies in underserved U.S. communities. The protocol for a pragmatic randomized controlled trial of the MyCog paradigm. Thank you.
All right. Hi, everybody. My name is Morgan Bonham. I'm a clinical research associate at Northwestern University's Feinberg School of Medicine, and I am situated within the Center of Applied Health Research on Aging. And I've been working with this group since about 2016. I'm primarily involved in leading research projects from our cognitive aging program. So today I'm excited to have the opportunity to introduce the MyCog trial to you all. First of all, I have no financial disclosures to share. And next, I do want to acknowledge the study team. Many of you are in the room today. These individuals are from the Division of General Internal Medicine and Medical Social Sciences at Northwestern. And then I also want to acknowledge our community partner, Oak Street Health, who I will definitely introduce in further detail later on in the presentation, just for their many contributions to the trial thus far. So first of all, a few of these slides may look familiar to you, but I want to remind you all from Dr. Wolf's presentation from earlier this morning that this research is supported by the National Institute of Neurological Disorders and Stroke and is being conducted as part of the Consortium for Detecting Cognitive Impairment, including Dementia, which I'll refer to as Detect CID. And these are with collaborators from Northwestern, Einstein, and UCFS. And so published in JAMA here, our colleagues at UCFS, Kate Pacine's group, have highlighted the disparities in terms of timely detection and follow-up, especially among Asian, Black, and Hispanic adults. And with the start of consortium in 2017 until present, a high priority of Detect CID has been to develop tools that are suitable for primary care settings that will increase the frequency of detecting cognitive impairment and improve evaluations. And so here I wanted to highlight what was included in the RFA and what specifically the trial seeks to respond to, which is to address the unmet need to detect cognitive impairment, including dementia, in large and diverse populations seen in primary care across the US. And this is not just when a patient has a concern, but also when a relative, caregiver, or medical provider has a concern. So this trial has to meet three major requirements. And this is that it must be implemented in health disparate populations, it must be integrated into the EMR, and it must provide turnkey clinical recommendations. So in regards to the consortium, we are now in Detect CID 2. And so the goals of the MyCog trial are to incorporate MyCog into a different EHR. So we've done this with Epic with Northwestern Medicine. With Epic being used at many large health systems, we wanted to pivot platforms used more commonly in community health centers. Our strategy is to be implemented in Latino and Black communities who bear a disproportionate burden of dementia and lower rates of timely detection and diagnosis. And we want to see if MyCog can address health inequities, and we want to further examine study implementation, including costs. And so the MyCog assessment is available in, it's in DCCS and PSN that Ms. Curtis explained to you just a moment ago. It can be completed in English or in Spanish, and Spanish is a new component for the trial. And so language is simply selected by the clinician prior to administration, and it's based off the patient's preferred language. And it was very important for us to prioritize making MyCog available in Spanish, as this is just one step towards expanding the utility of MyCog in primary care settings. And our community partner also strongly supported our effort in this area. And so now I want to introduce our community partner in more detail, Oak Street Health. So Oak Street Health is a network of primary care centers for adults on Medicare who are 65 plus. And I want to note, in February, they were purchased by CVS Health, which is one of the world's largest healthcare companies. And just so you can see the spread here, this includes about 169 medical centers across 21 states. And Oak Street Health supports a diverse population strategically located in easy access in high density retail locations across the nation. And so here I just wanted to specifically highlight our performance sites. You can see them in green here. So there are 5 states included in the trial. It's Illinois, Michigan, Pennsylvania, and the Carolinas. And 24 clinics are included, and there's 12 intervention, 12 control. And with the MyCog trial, we're expanding to less urban areas and to states outside of Illinois, which is super exciting. And then a few more details about their EHR specifically. So Oak Street Health uses Greenway, Prime Suite, and Canopy software. So this has been a really unique challenge in integration as we're working with 2 different systems instead of just one. So in the simplest way I can explain this, our tech teams were able to work together to customize an integration into Canopy, which then reflects into Greenway. So these 2 systems are able to communicate with one another. And so again, back to the same workflow, 3rd time today. You can see this workflow again. Ms. Curtis showed earlier in her presentation, but I'd like to note that we can deliver MyCog for annual wellness visits and for routine visits, meeting annual wellness visit requirements, and also if there are concerns. But what I really want to focus on is the difference in clinical workflow, especially when there's a positive result. So I'm just going to fade that away and introduce you to this a little bit more. So Oak Street Health has the capability to refer patients to a specialist outside of the center, and this is called Rubicon MD. And for those who don't know about Rubicon MD, Oak Street Health acquired them in October 2021, and they are a leading technology platform providing access to specialist expertise. So this enables Oak Street to integrate virtual specialty care into their existing care model. And this is to significantly streamline the referral process, better manage costs, enhance patient experience, and provide more comprehensive care. There are over 230 specialists covering all major specialties. And so getting close to the end of the conclusion here, I just wanted to give you a little status update on where we're at the moment. So we are working to finalize the pilot, and we have already gained much insight from clinic staff for implementation, which has been great. For example, we've been streamlining the app to be more efficient, updating some screen visuals just for better clinic workflow. And then in terms of implementation challenges, we've made changes to the app for the use of a QR code instead of a barcode. And while we could use our Epic integration with the Toolbox Detect project as a guide and a foundation, we still had to completely customize the EHR integration into Canopy and Greenway to meet Oak Street Health's security measures and requirements. And with that, I want to mention that our limitations are that we are collecting data from only Oak Street Health clinics and that we will be relying on EHR outcomes primarily. And that is the end of my presentation. Thank you so much.
All right, thank you very much. Let's see. I'm not sure if we can advance the slides back to our, we're doing this. Okay. Oh, this one. Thank you. Perfect. Oh, here we go. It's okay. Yeah, I'm fine. All right. Thank you all. And so for our next group of talks, we'll go one to the next. Would you like me to introduce you all right now or one by one? Whatever's easier. Whatever's easier.
You can do all of us.
Okay. All right. We'll do them all. So this is going to be a suite of 3 presentations on MyCog on the tablet and mobile program. So we'll start off with Dr. Nowinski, who is going to be speaking about remote cognitive screening of healthy older adults for primary care with the MyCog mobile app, an iterative design and usability evaluation. We'll then continue on with Dr. Stephanie Young, who will be presenting on remote self-administration of cognitive screeners prior to a primary care visit, a preliminary evaluation of the reliability and usability of the MyCog mobile screening app. And then we'll finish up with Callie Jones, who will be talking about the construct and clinical validation of MyCog mobile, a remote smartphone-based cognitive screener. All right, thank you.
All right. Good afternoon, everybody. I am very excited to tell you about MyCog Mobile, which is the smartphone-based version of MyCog. Yeah, doesn't do. Nope, wrong way. Technology. So I'm going to provide an introduction overview to MyCog Mobile, and then it'll be followed up by Stephanie and Callie, who will tell you about our projects that we're doing. Okay, you have already been presented with the rationale for doing cognitive screening in primary care clinics, so I won't go over those again. But I will say that MyCog Mobile is another attempt to meet that need for a valid, reliable, accurate, and feasible way to assess cognitive function in primary care clinics. So if you were here this morning and heard Mike Wolf's talk, this is again part of it. We are trying to provide a suite of products that can meet different needs for different clinics. All right, so MyCog Mobile includes many of the same features that MyCog does. So it can be done prior to a primary care visit. It is self-administered. Results are automatically sent to the EHR when the patient is done, and there the physician can view them and before the patient actually comes in. And as it was in MyCog, if the patient scores in the high risk for cognitive impairment range, then appropriate best practice alerts are automatically available and put into the EHR. And then the clinician can discuss those recommendations with the patient and the family if needed, and then decide on what are the next steps. What is different about MyCog Mobile, again, is it's a smartphone. It doesn't use it's for remote assessment, so it's not going to use the same kinds of ways of getting into it. So, instead of having a barcode, it will probably be something through like MyChart. So they will download the app, and then they will take it on their own. It also looks a little bit different, as you can see. It's called Cognitive Checkup. So there's been some, design elements to make it more appropriate for someone doing it on their own. MyCog has been able to take advantage and leverage two other projects. So MyCog itself, which is the tablet app, and was designed for in-person administration. And then the mobile toolbox, which you heard about earlier today too, which is a research tool that was developed for remote assessment of cognition and other supplemental scales. So we took what we learned from those two projects, measures, technology, and we are creating this remote clinical tool. And it uses 4 measures that are either in MyCog or mobile toolbox in both. And we adapted them for this particular use, remote self-administration before a primary care visit. It currently includes these 4 measures. Plus, we decided to add 3 survey questions, one to get information about subjective cognitive concerns, because as you heard in some of the other presentations, that it's not, these measures, these products are not aimed only for an annual wellness visit, but also if there's a concern in between visits or a concern raised as part of a visit, so that we can also administer it for those cases. We wanted to know, is there a concern? We're also asking about age and education. So with 4 measures and these additional 3 survey questions, the MyCog Mobile is currently longer than we want it to be for a self-administered battery. So our long-term goal is to reduce the number of measures in order to reduce testing time. And we're going to do this by we're running a clinical validation study, which you will hear about in one of the later presentations. And we're going to use the data from that to decide which are the best measures out of those 4 that will predict cognitive impairment. And so again, we want to, even though it's self-administered remotely, we want to make sure that it's not too long so that the people actually do it. Now I'm just going to briefly describe the measures that are included. And these have been adapted from existing measurement systems. So the first one that is in the battery currently is the face name associative memory exam, which was, the original version was developed by Doreen Rentz. There is a version in the NIH Toolbox, and there's a version in the mobile Toolbox. And it is presented in terms of an initial learning trial where the person is, does some processing so they will remember these face name pairs. So it's a face name pair. Then we have a delay, and then they have these 3 subtests where we assess their memory for the face name pairs in 3 different ways. Do they recognize the face? Can they match the name and with the correct face? And can they recall the first letter of the person's name? And the score on this test is how many they could correct on all 3 of these. They also get a cognitive control executive function test, which is, we call it My Sorting in MyCog Mobile. It is an adaptation of a measure in the mobile toolbox, and there's also a version in MyCog. And what the person has to do is they have to categorize the image by color or shape. They are presented with the word shape or the word color. They do the categorization, and the measure switches back and forth to assess their cognitive flexibility. We also give them a working memory measure. This was adapted from sequences in mobile toolbox, and it's a well-known existing paradigm. Participants are presented with a series of numbers, and the series gets longer depending on how many they could correct. They get the sequence of letters and numbers, and then they have to remember them and sort them in their mind, and then order them by the letters first, then by numbers. And then finally, we have My Pictures. This is, again, an adaptation of a test that's already in the mobile toolbox, as well as MyCog, because, again, this is a version of MyCog. And it is an episodic memory test. They see a sequence of pictures, and the sequence is in a particular order. It doesn't have to be logically arranged that way, but they see it in a particular order. There's a brief audio description. The pictures scramble themselves, and they're asked to rearrange the images in the order by putting them in the series of, as you can see on here, these open boxes. So they start out with a 4-image practice trial, and then it jumps up to 12 images. 12 images. We had to do some adaptation because in terms of changing it from MyCog because of the screen size. We want to be able to make sure that the person can see these 12 pictures clearly enough on a small screen. So those are the 4 measures, and that's a brief sort of overview of what MyCog Mobile looks like. And now my colleagues are going to present the findings, or at least the plan of 3 ongoing studies that we're doing on MyCog Mobile. And the studies look at usability, they look at feasibility, and then the construct and clinical validation. All right, well, thank you. Now I'll turn it over to Stephanie.
Looks like our acknowledgement slide did make it into the deck, so that's great. So again, acknowledging folks on the project, thank you so much. All right, so I'm going to talk about two of the studies that we've already completed using MyCog Mobile. The first one is a usability study and just a little bit about the design. And then a pilot study that we completed with the version 1 of the app. And I'm just going to briefly give an overview on these, but both of these studies have been published in JMIR, and I'll give you the QR code link there if you want to look at more information about them. So when we sought out to make the MyCog mobile app, we knew that design was going to be really important for a self-administered smartphone app, right? This is something that you're going to use on your own personal smartphone, and you don't have as much control over participants when they're taking it. And so as Dr. Wolf mentioned earlier today, kind of that iterative design process was very important. And we used a human-centered design approach, and we did have UX designers helping us with this and giving us some input. But what that really entails is kind of gathering data from the end users, and that could be, adults who are over age 65, but also our clinical end users. So there's multiple people who are kind of involved in this process, including the PCP, including the MA, including practice managers who are kind of adopting MyCog Mobile at their clinics. And so we would gather information from each of these different stakeholders and sort of, use that to inform the design kind of piece by piece as we develop the app. So I'm not going to go into too much detail about the whole process. I'll just kind of give you a brief overview of who we talked to. So we started out talking to clinicians. These were mostly primary care providers or people who worked in gerontology, and they kind of gave us a formative interviews, and that's where we thought of, kind of the foundational design of MyCog Mobile, like what does it look like, how does it work, how is it taken, what are the things that they really value out of it. We also spoke with clinic administrators, so that would be like medical assistants or practice managers, to kind of understand what would be the best workflow for actually implementing this in a clinic. And then, of course, we talked to older adults who would actually be the people who use this on their own smartphones. So we did a community stakeholder panel where we spoke with a bunch of older adults from diverse backgrounds and kind of about their opinions and attitudes about using a cognitive screener like this on their own smartphone. And then we also did individual interviews with folks and had them actually interact with clickable prototypes of the design so we could get some feedback there. And so findings from the data collection with these different stakeholders kind of showed us that people care about different things. So when we spoke with clinicians, the things that they care about are, using well-validated screening tests, being able to view the scores within their own EHR was really important, right? So you're not actually taking some scores from a piece of paper, hand scoring it, and then entering it in the EHR. It's automatically populating. And then also being able to know what to do with the scores when they get that. So having best practice alerts, okay, I have a positive result. What's the next step? For staff, it was important to kind of efficiency is the most really important thing, is kind of minimizing the staff involvement in the screening process. Most of these clinics are very strapped for time and staff resources, and being able to kind of easily communicate with the patient what the situation is and move through the process seamlessly. For patients, they cared about, a lot of those things as well, but really, am I going to be getting good results? Am I okay, right? Those are the motivations to take these screening tests, is monitor change over time and know if they have some sort of problem. And then there's also shared priorities by these different stakeholders, but really the main priority that we found that was in common across all of the people who would be involved in this process is being able to save time during their in-person visit to focus on other things that are more important, right? So taking a screening test in an in-person visit takes time, and if there's nothing wrong and there's no concern, we don't need to take up that time during your visit. So based on all the information that we got from these different stakeholders, this kind of shows the user journey of how they would use MyCog Mobile. So a patient schedules an annual wellness visit. It might not be just an annual wellness visit. It could be just a primary care visit, as we've spoken about before, or some other type of visit. And prior to the visit, they would receive a message from their clinic that says, you know, it's time to complete MyCog Mobile. Your doctor has asked you to complete this. Please download this app. They will download that onto their personal smartphone, complete the measures. They're completely self-administered, so they're doing this all on their own. And then as soon as they're done, those scores are sent directly to the EHR and populate within the EHR so the clinician can see that. If there is a positive result there, they will also get best practice alerts that's telling them, like, okay, here's the next step. And this allows the clinician to actually prepare for the visit before the patient comes in, if they like. And then during the visit, that's when the patient will get the results. They'll talk about, you know, get appropriate referrals and next steps in that way. So just a few key takeaways and design features that we learned from this iterative design process. Again, that main benefit of MyCog Mobile is saving that in-office visit time. MyCog Mobile is best self-administered by the patient remotely on a secure app. And so one of the main things that we learned right away was that this was just could not be proctored anyway. These clinics are too strapped for time. And so in this way, it's completely on the patient to complete it. We did learn that patients wanted to know kind of why are they taking this and what the process is going to be. So it was important for us to make really clear introductions and exit screens about this is what's going to happen. This is what you can expect. This is when you'll see your results. And then also making sure that we had a user experience design that was really optimized for older adults, for everyone, but older adults in particular. So simple interactive task instructions, large tests, kind of simple, easy to use gestures on the phone, like tapping instead of dragging, things like that. Okay, so I will talk briefly about our pilot study. So that was the information that we took to design and actually develop the version 1 of this app, which we did make a smartphone app that was ready to be used by patients. So we conducted a small pilot just to kind of see the feasibility of actually completing this on their own. So our research questions for this pilot were, can older adults complete this battery, MyCog Mobile, remotely on their own smartphones with zero support? What are the reliability of the measures? So we looked at internal consistency and retest reliability when it's taken remotely. And then we did some usability work in this as well, is that, you know, how do these patients rate the user experience of using the app? So we had a sample of 51 participants here. I don't have the overall N there, but it's 51 older adults around the age, mean age was 74 years old. They were emailed instructions about how to download the app onto their own smartphones. And then they completed the 4 activities on their smartphones and a brief survey about usability remotely with no help. And then after 2 weeks, they completed them again. So we found that 100% of the patients in our sample were able to successfully download the app and complete all 4 measures at the baseline. And we had pretty good follow-up there. So only 2 people did not respond at follow-up, which was promising. And the mean usability ratings on our usability scale indicated a positive user experience, above average. We found, I'm not going to get too much in the weeds with this here, but we did found acceptable reliability, so both internal consistency and retest reliability for each of the measures. The no practice effects except for, I think my face is here, which as Dr. Renz mentioned before, that's what we would expect. This is a healthy population, and expected correlations with education, except for my pictures, was not significant. So overall findings from this study, healthy older adults in our sample can reliably complete MyCog Mobile remotely on their own smartphones. The measures have acceptable reliability metrics. They correlate positively with education as we would expect. My pictures did not correlate with that, but that might be due to things like cheating or self-selection bias. And that's something that we're going to have to look at in our next study. And then overall, participants in the sample rated the usability of above average, which means that, you know, they're having kind of a good experience, a positive experience completing the app. So if you are interested in the studies, they're both on JMIR journals, and I have the QR codes right there if you'd like. But yeah, that's all I had, and I'll have Callie talk about our upcoming study, which is a clinical and construct validation of.
Okay, hello everyone. My name is Callie Jones. I'm a research coordinator in the Department of Medical Social Sciences in the Feinberg School of Medicine at Northwestern. And as Stephanie said, I'll be talking about the joint construct and clinical validation of both MyCog and MyCog Mobile, which is an upcoming study that we're running this year. So we went into the study with these 3 research questions. First, is there evidence of construct validity of the MyCog Mobile measures when compared to gold standard neuropsychological assessments and cognitive screeners? 2, can performance on MyCog Mobile accurately differentiate between older adults with cognitive impairment and older adults who are cognitively normal? And 3, can the MyCog Mobile battery be shortened but still maintain adequate prediction abilities? So this is our target sample. We are ensuring that it's stratified by age, race, gender, as well as ethnicity. And we have a maximum of 70% white non-Hispanic people and maximum of 50% of people with a bachelor's degree or higher to ensure that we don't get a homogeneous sample. And these are the procedures we're following. So we have 2 groups, a healthy control sample with an N of 200 and a clinical sample of 100 people. For the healthy control sample, we're looking at adults 65 plus with no history of cognitive impairment and a mini-cog score of greater than 5. We're recruiting these adults through an external market research agency, and they're going to be administered a battery of external gold standard measures in person, and they're going to self-administer MyCog and MyCog Mobile in the lab. The clinical sample, we're looking for adults 65 plus with a mini-cog score of less than 5 and a documented diagnosis related to mild cognitive impairment, dementia, cognitive deficits, or other memory loss. And we're recruiting these people through specialty memory care clinics in the Chicago area. We're also administering the mini-cog to these adults, and they will be self-administering MyCog and MyCog Mobile in the clinic as well. So these are the measures of convergent and discriminant validity we will be using. This is our test list and plan for measuring convergent and discriminant validity. And these are proposed analysis. We'll be looking at correlations between similar and dissimilar measures. So for convergent validity, we're going to look at measures of similar constructs. So for example, verbal paired associates and my pictures from MyCog Mobile, which are both memory tests. And these will have higher correlations we expect. For discriminant validity, we're going to be looking at correlations between measures of dissimilar constructs. So for example, the trail making test versus MyCog Mobile's My Pictures, because the former is a processing speed test while My Pictures is memory test, and we expect these to have lower correlations. We'll also look at internal consistency again in this sample. And in the clinical sample, we will explore models that best predict clinical group status and see if we can reduce the battery to only the tests that are the most predictive. So our next steps is we're starting data collection next month. We're going to conduct analyses over the summer, and then we will refine the app to make a final version based on prediction model and user feedback. And then we're going to field test next year in a primary care clinic. And actually, our article in BMJ Open Protocols just got published yesterday. So you can go check that out. Thank you.
All right, thank you very much to all our speakers. So I'm going to open it up now for question and answer period. Does anyone have any questions? You can either raise your hand and speak up or come down to the microphone. Yes, sir. And actually, before you answer, I'm going to just repeat the question for those online because I think they may not have been able to hear. But this was a question from a practicing gerontologist who's using MyCog in the home currently with older adults and had a question about the availability of MyCog mobile for use if he has already subscribed to the MyCog service. Is that a fair recapitulation? Again. All right.
Is this on? It is on. All right. MyCog Mobile is still in development, and so it's not available for public use right now. If you wanted to talk with us, we'd be happy to talk with you about collaboration or in the future. But right now, we still have to finalize the measure.
All right. Other questions? Yes, and would you mind coming up to the microphone if you asked to? Thank you.
Thank you all for your great presentation. And this may be more across all the applicability, but is there any talk or planning stages for people with hearing or being blind? What word am I looking for? Vision. Thank you. Vision impairments. I guess I could have a mini talk. But anyway, is there any talk of that? Thank you.
That is a great question, and it is something we'd like to consider in the future because, as you could see, based on the examples we showed of these tests, they are heavily dependent on vision. I mean, you have to see them. So right now, we don't have any alternatives to that, but we do think it is important. Now, the MyCog mobile version, you can use some of the accessibility features of the phone, because these will be the person's own smartphones. So there will be that, at least to some extent. But for the MyCog battery itself in clinic, it's static.
That, add to it. All right, thank you.
The only other thing I would add is that, as Mike Wolf had in his, I think in one presentation, there is no one size fits all solution. So we know we can't be the product for everybody.
Oh, to me. All right. So, weird here to miss. Quick question. I noticed that the app, the MyCog Mobile, was on iOS. Is there any plans for it to be made available for Android, given that, if you're deploying this in a clinic, you're going to have a mix of patient devices?
So right now it is only iOS, but that was just kind of our first proof of concept. But we do have plans in the next phase to also develop an Android app. But like Dr. Nowinski said before, like we're still kind of figuring out what's the final battery, and finalizing everything. So, but next round.
Thanks. Very useful presentation. And maybe I missed it, but you're using the healthy elderly to compare with the gold standard neuropsychological measure, but not the clinical battery. Is there a reason for that?
Turned it off. Is that better? Can you hear me? Okay. We are going to give a MyCog to the clinical battery and then also the MyCog mobile measures. But giving like a lengthy neuropsych battery was, we're recruiting these patients from community clinics. And so it's really burdensome for them to do a long neuropsych battery. And so we're using kind of as our outcome measure is just clinical group status. So if you have a diagnosis of one of the ICD-10 codes that's related to dementia, that's sort of the outcome variable, but it is a limitation not having all the gold standards on the clinical code. Good question.
Hi, I just have some technical questions. Do you sync with do the results go to any EMR or is it just Epic? Or what is it?
So right now, it is either Epic in clinic, or as we heard about MyCog trial, it's going to be, it sends the results to their Canopy Greenway system.
Okay.
MyCog Mobile, because we're going to be doing an initial evaluation and validation at Northwestern, it's going to be Epic again.
Okay.
But one of the things that we're very aware of and that we want to do as much as we can is to have a product that is scalable to other EHRs, but we need to start somewhere.
Right. And you're not presenting any results to the participant, to your patients, right? That'd be too hard to interpret or maybe scary or something, right? Would you think about that in the future?
So that's something like in the usability studies that came up, is like, I want to know how I did. But that's always tricky, right? When you're doing kind of a self-administered neuropsych test, you don't want to tell someone, oh, you just took this on your phone and you have dementia or something like that, right? And so we're pretty clear, like in the instructions to say, like, you will talk about this with your doctor when you go into the visit, because it is just a screener, right?
Yeah. And that's pretty common now. We all take screeners and like fill things out before we go. So that makes sense. Speaking of your usability, have you published those usability studies? And are your questions in the paper? We have
like
an app.
Yeah.
Okay.
There was, I only had 6 minutes and I had to get all those in there, but it goes through kind of that whole process, starting with like those foundational interviews with those clinicians and then, talking with the MAs and doing the panel and all of those kind of different stages up until the last stages when we actually had those high fidelity prototypes and they were using them.
Okay.
So that's
Cool.
all.
Okay, great. And then I don't remember why I wrote this down, but I wrote, do you have reminders? Like, was there a task that they have to take again?
It's a good question. Or just reminders to take it? Like,
right. Are there any notifications?
I think that's something that we're going to learn when we do the field test, right? Is right now it's just a pilot, right? So all of it is a research study, but we have to kind of see how this is used in the real world of, your clinic sends you a message, hey, do this, but how many times are they actually filling out paperwork before they come in, let alone doing this cognitive test? I think that's going to be one of our challenges.
Yeah. Okay, cool. Great job.
Got another question coming.
Hi,
Not done yet. A few more minutes.
this is Armiel from Florida Atlantic University. Just to clarify, if I understand it right, that on the process of developing this MyCog for the public use, are you anticipating that it's charge-based, that we have to pay for those community or based on institutional use or for those clinics, or because it's an NIH-funded study and it's like open to the public?
That is always a great question on how do you get these products. Right now, they're not publicly available, neither of them. MyCog is in clinic, so we are using it. And that's why I said, we have contact information. You can talk to us about collaborating with us. And I say collaborating because it's not a publicly available product. When it does become a publicly available product, there may very well be a cost associated with it, as there is with NIH Toolbox and Baby Toolbox, because you have to keep these things up and you have to manage them. So if there is any cost down the road, that would be for that purpose. It's not to make a profit. If you want to, talk to one of us about using MyCog at your clinic, the challenge is going to be even if you're at an institution that has EPIC, it's going to be a particular instance of EPIC. And so having our products talk to that EPIC instance is going to, require some work. So that's one of the things to think about, but which we are, like I said, we want to make it scalable, so we want to make it as easy as possible.
Well, thank you, everyone. Any more questions from the audience? No. I may ask a quick question. This is actually directed towards Stephanie. I noticed when you were talking about the results that you've seen, and I believe this was a picture task that was unexpected, and you were trying to think about possible reasons for that, which could include cheating. Or I was wondering, and perhaps you'll be able to better assess that as you move forward with more people. But how do you go about assessing that with a task administered remotely and at home? And what are some of the things you're thinking about as you're thinking about the tools that you're using?
Yeah, you mean like, are they cheating?
Yeah.
Because we do think about that quite a bit.
Yeah.
So we don't have a way to control for cheating right now. I think, something as simple as like saying, this is to screen your cognitive health, please don't cheat, I think can go a really long way. We did look at, so that task is adapted from the mobile toolbox, and we did look at that. We just published a public paper about the validation of the original mobile toolbox version of that app, and looked at, are we seeing these kind of like uniformly high scores because they're writing it down? And we didn't really see like definitive evidence of that. But I have thought about ways of like, how might we embed like performance validity metrics into some of these tasks? But yeah, I mean, it's a good question. We don't know if they're writing it down. We don't know if someone else is helping them. And that's another limitation, I think, of like remotely self-administered methods.
Yeah, thank you very much. Did you want to?
No, I think.
Yeah, I think right there. Yes, it's many potential benefits and also some potential limitations. But all right, well, I think we're nearing the end of the time, but I want to thank you all for a really terrific session. Thank you. And before we part, I actually have a message, which I need to pull up on my phone again, about our next session. So we have a 15-minute break, or just over. I think we might be stopping a minute or so early. And we'll be reconvening at 2:15 for the second portion of the concurrent sessions. Those will be session 4 through 6, and session 4 is the use of the NIH Toolbox in diverse populations. That will take place in balcony A. Session 5 is the NIH Toolbox in developmental clinical populations, which will take place in balcony B, the room we're in right now. And then session 6 is the NIH Toolbox across the lifespan and in clinical populations, which will take place in the main auditorium. All right. Well, thank you very much, everyone.
One more thing, can I make it's in your schedules, but make a plug. Come to see the demonstrations. Try them out. And, we're going to be at tables, ask the experts. So please come talk to us.
This is the NIH Toolbox use in developmental clinical populations. And we're going to get started with Dr. Emma Condy from the National Institute of Mental Health, talking about the NIH Toolbox Cognition Battery Feasibility in individuals with Williams syndrome.
Hi, everybody. So actually, unlike a lot of our other speakers today, I'm from the intramural program of the NIH. So there's the extramural side that does the grant funding and things of that nature. But I did my postdoctoral training here in the intramural program where we conduct research on campus. So this was work that I did during my postdoc. If anybody wants to hear more about training opportunities at the NIH, feel free to come chat with me during the poster session. But during that time, we do a lot of measure development in populations with intellectual disability. And so this project was specifically focused on a disorder called Williams syndrome that we collaborate with one of our colleagues in NHLBI, which is the Heart, Lung, and Blood Institute on. So Williams syndrome, the behavioral phenotype of it is it's a neurogenetic condition that's caused by a microdeletion on chromosome 7. And so the participants in this study were enrolled as part of a natural history study where they come in approximately once a year to see behaviorally, cognitively, how they're doing, as well as a full medical workup by the NHLBI team. And their neuropsychiatric profile includes mild to moderate intellectual disability, but it also includes anxiety as well as attentional deficits that we thought would be interesting to try to index using the NIH Toolbox. So to do that, we decided that the early childhood cognitive battery would be the most appropriate set of tasks to use with these particular participants. So we administered the flanker inhibitory control and attention task, the dimensional change card sort, the picture sequence memory, and then we skipped over the PVT because we already were giving them the on-paper version of the PVT in our clinic setting. So we did the other three with all of them and then wanted to look specifically at the feasibility of administering those core tasks in the early childhood cognition battery, as well as whether or not performance on those tasks correlated with any of the other cognitive variables that we were getting from them because they were undergoing full IQ testing, as well as a variety of other things like the CBCL and other cognitive and behavioral tasks or assessments. So we had 47 participants with a Williams syndrome diagnosis come and undergo testing. Williams syndrome was confirmed via molecular testing by the NHLBI team. They were between 4 and 50 years old because, as I mentioned, this was a natural history study, so there really wasn't an age limit. It was just whoever was available to come in, but the median age was around 20 years of age. The majority had a full scale IQ of less than 70, so they would meet that cutoff for intellectual disability, but the median was around 58. And notably, individuals with Williams syndrome have relatively preserved verbal skills, which for the NIH Toolbox makes them a particularly great candidate neurogenetic condition for assessment. So they underwent neurodevelopmental phenotyping, which included demographics, developmental history, and IQ testing, as well as this early childhood cognition battery. And then our analytic approach was to look at feasibility via the completion rates, so who was able to validly complete the tasks, as well as relationships with other variables. So Spearman correlations between age-corrected standard scores from the toolbox, as well as uncorrected standard scores with nonverbal IQ and chronological age. So for the flanker inhibitory control task, we had an 89% completion rate, which we then broke down into looking at whether or not the scores provided by the NIH Toolbox task were coming up at floor for the age-corrected scores. So the NIH Toolbox is normed such that you get 3 standard deviations below the mean score and then 1 point is the lowest score you can get if you're looking at the age-corrected score. So that's a 54. Now, conversely, most standard IQ tests go down to 4 standard deviations, so we were particularly concerned about floor effects with the NIH Toolbox tasks. And what we found was that for the flanker, of the 89% that were able to successfully complete the task, 27% were scoring at that 54 of a floor when we looked at the age-corrected scores. But overall, a pretty high completion rate for our Williams syndrome patients on this task. And then the scatter plot on the right-hand side is showing the age-corrected scores in black, where you see that floor effect is particularly pronounced for participants over the age of 20. And then compared to the uncorrected standard scores, which act more as a kind of change score, right? So they can't necessarily be compared between subjects because we're not controlling for age with these scores, but within a subject could be helpful to tell us if their skills are increasing over time. And those uncorrected standard scores show a slightly different shape in our participants than the age-corrected scores did. And that's highlighting the floor effect. And then on the dimensional change card sort task, again, this was administered to 47 subjects. There was, again, an 89% completion rate, and about 19% of them completed at floor. So again, it's occurring in that same subset of individuals that are around age 20 and older. So the adults seem particularly affected by this. And again, on the right-hand side, you're seeing in black the age-corrected standard scores versus their uncorrected standard scores. So a slightly different looking curve. And then finally, the picture sequence memory task did not appear to show a floor effect. So we got, again, an 89% completion rate here. So high completion rates across all 3 tasks. However, we didn't see this issue of our participants scoring at a floor on this task. And again, you can see on the scatter plot in blue is our uncorrected standard scores versus black, which is our age-corrected standard scores. And then if we look across all of them, right, all 3 tasks, again, about 79% completed all 3 tasks. Only 1 participant was unable to complete any task, right? So there was, out of our entire sample of 47, 1 participant just couldn't engage with the iPad in a way that we felt was appropriate to consider a valid score. However, any other missing data was not coming, right? That 89% completion, it wasn't that the same people kept failing for the 3 tests. And most of the invalid administrations in this sample seem to be to an inability to pass the practice, okay? So it was that they just never got even to the scored part of the test because, for example, on the dimensional change card sort, they never got past the simple training of shape versus color, okay? Then when we looked at relationships with some of the other variables in our sample, specifically age-corrected standard scores versus age, chronological age, and nonverbal IQ, we found that age correlated highly with the flanker age-corrected standard score in this sample negatively. So as you had participants of higher ages were showing lower scores, which tracks with the fact that we were seeing those floor effects for our older participants. And then you saw a similar trend, but not to the same extent in the DCCS, where we saw a correlation of negative 0.45. And then there was also a relationship between DCCS and the flanker age-corrected standard scores in the positive direction, which is perhaps unsurprising since they are both measuring executive function. However, the part that we were a bit more concerned about was that nonverbal IQ did not correlate with, right, I'm not pressing the correct button, did not correlate with any of the NIH Toolbox scores, which was a little bit of a concern for us. And that's, again, showing that it did not correlate with any of those things. Those were the correlations. So overall, we found good feasibility of the flanker DCCS and picture sequence memory test in Williams, which is a population that has mild to moderate intellectual disability. We had some concerns with using the age-corrected standard scores in this group, particularly for the flanker and the DCCS because of those floor effects that we observed, as well as the pretty notable negative correlations with age and no correlations with nonverbal IQ, which again indicates that perhaps it's not sensitive enough to be able, at the lower ends of the scale, be picking up on actual skill. Thank you.
Thank you so much. Our next speaker will be Shreya Arun from Virginia Commonwealth University, talking about in-depth analysis of fluid cognition in boys with Duchenne muscular dystrophy.
Hi everyone, my name is Shreya Arun and I'm from VCU, and today I'm going to be talking to you about fluid cognition in boys with Duchenne muscular dystrophy. So to give you an overview on the disease, it's named after Dr. Duchenne, who in 1861 described a cohort of young children, 24 boys and 1 girl, with extensive muscle wasting, speech delay, and a dull cognitive affect. Then, in 1987, Louis Kunkel identified the DMD gene, the largest gene in humans, on the X chromosome encoding for the protein dystrophin. Dystrophin is a cytoskeletal protein expressed in muscle cells, glial cells, and neurons. DMD is characterized by the absence of dystrophin and the resulting deterioration of heart, lung, and muscle cells. Subsequent research on DMD has been focused on skeletal muscle symptoms. However, our focus is on cognition. Through StarNet, a surveillance program that monitors patients with DMD across the country, we know that patients experience severe delays in gross motor skills, speech, and language. We also know that they have high rates of school grade repetition, especially in those receiving speech therapy. They also underperform academically when compared to their peers and experience higher levels of school-related stress. And in later years, they have trouble finding vocational opportunities due to the progression of the disease. So the CDC-supported care guidelines for DMD regarding psychosocial care recommends that patients be assessed by a neuropsychologist throughout their lifespan. With a higher risk for learning and intellectual disabilities, it's really important to screen and assess them for these conditions to provide early intervention. However, due to high out-of-pocket costs and lack of access to specialists, more than 75% of DMD patients have never been assessed by a neuropsychologist. So only in more recent years have studies been focused on cognition in DMD. But these studies have all been focused on IQ or IQ-based measures. Only one past study completed in 2019 utilized a subset of the NIH Cognition Toolbox, and they found that those with distal mutations in the DMD gene had significantly lower scores in executive functioning and working memory. This is supported by patient and parent reports that those with distal mutations typically have a higher They typically have a higher burden of disease. And other studies of note also noted that those with DMD have poor visual spatial attention skills. So our study wanted to find out whether distal mutations are more psychometrically affected than proximal mutations. And we also wanted to assess whether the NIH Cognition Battery Toolbox would be an effective tool in identifying the cognitive deficits in domains known to be affected by DMD. So we chose the Cognition Battery Toolbox because it's a short assessment that assesses 7 domains of cognition and provides 3 scores: the total composite score, the fluid cognition score, and the crystallized cognition score. Crystallized cognition is composed of vocabulary and reading, and the fluid cognition score is calculated by assessment across executive functioning, inhibitory control and attention, episodic memory, working memory, and processing speed. These scores can be compared to population norm data and can be assessed throughout the patient's lifespan. It also takes into account the mother's educational background when assessing children and the subject's educational background when assessing adults. So in a preliminary study by Dr. Thongaraj, she assessed 30 boys with DMD using the NIH Cognition Battery Toolbox. She found that when looking at the total cognition score, boys with DMD scored 1 standard deviation below the age-corrected norm compared to the norm. When looking just at fluid cognition, boys with DMD scored 1.5 standard deviations below the norm, with significantly lower scores in attention, processing speed, and working memory. There was no difference in scores when looking at crystallized cognition. So these findings were replicated in a second data set of 63 boys with DMD, aged 4 through 27. This time, we not only looked at the scores across each of the 7 domains, but we also compared scores based on DMD location. Similar to Dr. Thongaraj's study, we found that scores were significantly lower for attention and processing speed. However, we found that there was no difference in scores when comparing proximal mutations and distal mutations. So although distal mutations are known to have a higher burden of disease, through the NIH Toolbox, we show that there is no difference in cognition when comparing proximal and distal mutations. And it's also important to note that the NIH Cognition Battery Toolbox can successfully identify the relative deficits in attention, processing speed, and working memory. And these domains of fluid cognition are known to be affected by DMD as demonstrated in previous studies. The toolbox is a short assessment that can be completed across the patient's lifespan, and scores can be compared to population norm data. Thus, we propose that the NIH Toolbox be used as a clinical tool to screen and assess DMD patients for intellectual and learning disabilities, as it was able to successfully identify the domains affected by DMD. I would like to take a moment to acknowledge Dr. Thangraj and Dr. Kat for their contribution to this project. I could not have done it without them. And then thank you all for listening.
Great. Next up is Stella Wang from Northwestern University, talking about evaluating cognitive performance in children with classic galactosemia, results from the NIH Toolbox Cognitive Battery Tests.
I noticed the solar eclipse is happening soon, so I'll talk a little faster and leave more time for David. So today my topic is on the use of NIH Toolbox to evaluate the cognitive performance in children with classic galactosemia. And here's my disclosure. So let's talk a little bit about classic galactosemia. There are a lot of things on the slides. I just want you to remember classic galactosemia is a rare condition, but it's very serious. So it is a rare autosomal recessive metabolic disease caused by a genetic inability to normally process galactose. Galactose is produced in the milk and many food. When it cannot be transformed into glucose in those patients with classic galactosemia, it transforms into a sugar alcohol called galactitol. And galactitol is highly toxic. So when it builds up in the blood vessels and brain or organs, it causes massive complications. It is a rare condition, happened only about 80 children per year in the United States, and currently only about 3,000 adults and children have classic galactosemia. Most of them are under 40 years old. And it is a serious disease because before the newborn screening had included classic galactosemia into the panel, majority of the kids will not survive classic galactosemia. So within the 10 days, if they're not treated by lactose-restricted diet, they will die of massive infection. So thanks to the newborn screening as well as the lactose-restricted diet, it is the only option right now for these children. The infant mortality is significantly reduced. However, the galactose-restricted diet does not really prevent complications because the body also produces galactose endogenously. So you can see those children and adults survived a childhood or infant stage of galactosemia, also developed a lot of significant complications such as cataracts, speech and language issues, cognitive impairment, motor issues, fertility issues, behavior and adaptive skills is impaired, as well as tremor and seizures. So here I'm going to present a cross-sectional analysis of a longitudinal study that studied children with galactosemia called Action Galactosemia Study. It is a pharmaceutical intervention study and pivotal study. The agent is called AT-007, and currently it's in the NDA review. So I hope to present some future data, but currently I'm just talking about the baseline characteristic and cognitive profile of these children with classic galactosemia. So in the study, children 2 to 7 were enrolled with a confirmed genetic testing of a classic galactosemia, and all children are adhered to galactose-restricted diet since birth. So as you can imagine, it is very important to understand the cognitive profiles of these children, also to understand the progression of the disease and the treatment of the pharmaceutical agent. So we need to have a good measurement tool, and we choose NIH Toolbox. So why NIH Toolbox? I think I'm preaching the choir here. We all know the NIH Toolbox is not only reliable, valid, and can be used a wide age span from 3 to 85. And I think in our clinical studies, because we have children all the way from 2 to 17, it's important to include as many children as possible to use the same battery. So, which is important. The other thing I think in NIH Toolbox is really a nice tool for pharmaceutical interventions and studies, because really it's track the sensitive change of the score, as well as, the scoring and administration does not have to be done with experts. So we train the clinical sites to administer the test, and the score can be instantly available as soon as the children complete the test. So in this study, we use the age-appropriate task to test a wide range of all 7 cognitive tests with 7 domains, and we are using the age standard score presented here. By the way, all the tests was done in English. So this is a simple demographic table. I just want to point out a couple important things. The mean age is about 9.1 and is equal percentage of male and female. And these children come in with also some CNS disease background. Majority of the kids, actually more than 50% of children already has speech and language impairment, learning disorder, and some of them have behavior and psychiatric disorder diagnosed, ADD, ADHD, anxiety, depression, and many of them have also motor impairment, such as tremor and ataxia. So here we present first the cognitive composite score, the cognitive profile. These are 4 composite scores that generated from the NIH Toolbox. So as you can see, the total composite score is relatively low, close to 2 standard deviation below the mean. Here, the solid line is a population mean, and the 2 dotted line is 1 standard and 2 standard deviation below the mean. And crystallized composite score compared to fluid is relatively closer to the mean score, and also have a little bit less variability within the population. And look into a specific test across all domain here. I think we just look at previous study presented with compare, nice thing about NIH Toolbox is that you can compare score even within different disease. You can see these children with classic galactosemia actually have also more impaired in their fluid skills, and their crystallized skills is relatively closer to the normal score, but it is still mildly deficit. But in terms of their fluid skills, for example, the processing speed and the flankers are the lowest, and with also a lot of variabilities within this population. One more thing we're going to look at is based on the across different age group. We did analysis looking at proportion of children in their standard score fall into different severity categories. On the right, on your left, you can see the red bar are the children's had standard score less than 70, and the yellow bar is between scores between 85, 115, and a purple bar is average score. You can see children with 13 to 16 teenagers actually have more severe significant deficit. Over 60% of them have a standard score less than 60. So less than 70, sorry. So this indicates this progression with the disease. However, these are the standard scores, so it does not really, and it's a cross-sectional, so we don't have data currently presented in terms of longitudinal results. So if we have, in the future, if we use version 3, we can use age-sensitive score to track individual changes. So last but not least, I want to have a couple conclusion and discussion points. So the overall, the age-corrected standard cognitive composite score using NIH Toolbox, we can see it for these population is 75.3. And there's a significant cognitive deficit defined by age standard score below 70. And the majority of these adolescents had a significant deficit. Adolescents also demonstrate more impairment in executive function as measured by flanker and dimensional car-sort tests with a mean score around 2 standard deviation below the mean. And younger children exhibited a lower score in working memory, but a similar score in episodic memory compared to older children. And for receptive and expressive language for the 2 crystallized tests, younger children also perform better than their older counterpart. So overall, the older children experience more severe cognitive impairment compared to the younger children, underscoring the progressive nature of the disease. And these findings definitely support the importance of targeting cognitive development in the early years and the need for pharmaceutical intervention to prevent further decline among children with classic galactosemia. Thank you.
Our last speaker will be Dr. David Hessl, talking about the NIH Toolbox Cognition Battery and its utility in clinical trials for neurodevelopmental disorders.
Hi, everyone. Okay, see if I can learn how to work this. Okay, great. So I'm David Hessl. I'm from UC Davis. I've been the PI of a longitudinal project that has been focused on the NIH Toolbox Cognition Battery in people with intellectual disabilities for the past almost 10 years now. We've had 2 cycles of funding from NICHD, and this last one actually is partially supported by the Include Down Syndrome initiative. So we're really grateful for that support. It's been really an exciting part of my career. I have this quote, "This is where the rubber meets the road." And I say that because I've learned over the years that when it comes to interventions and clinical trials, the selection and sensitivity of the outcome measure that we use for these trials is really where the rubber meets the road. It's where we decide and we determine whether an intervention is effective. So it's a really, really important thing to focus on, outcome measures. These are some of my disclosures. I've been involved in Fragile X syndrome research for almost my entire career, and now I've been involved in some Down syndrome studies as well. So I do have some disclosures here to say that I've been supporting different translational research efforts in both Fragile X and Down syndrome. So I like this image because it depicts just how much effort and training it takes to achieve a goal. So I love track and field, and one of the events that I always felt like I wished I could have done was the pole vault. And when you think about pole vault, it takes so many different components to be successful. You have to be fast, you have to be coordinated, you have to be strong, you have to have some technical expertise. And what I want to try to convey is that this effort to validate measures, not only for use in a population, but for use in clinical trials, it's a very high bar, and there's a lot of different components to being successful. So what raises the bar? Of course, the test has to be doable for the population you're interested in. It has to have an adequate range to capture the variability in the population. It has to be reliable over time. So we talk about test-retest reliability or stability of a measure when there's no, quote, real change happening. And so that's especially important to look at the interval of time that you'd be studying in a clinical trial. Some tests that we use, especially in the cognitive domain, can have practice effects. So you'd like them to have less susceptibility to that. You want them to be sensitive to change. So when there's a treatment and somebody actually gets better, you want the measure to be able to detect that change. Ideally, the measure will have established links to the known cognitive phenotype of the disorder if you're focusing on a cognitive measure. So you want it to kind of align with what you'd expect to see. A bonus is if the measures have known underlying brain mechanisms that are understood in people who are typically developing and are deficient or aberrant in people who have the condition. And then this last one, which we've been working on a lot lately, is the concept of clinical meaningfulness or importance. So when we have a measure that we do in the lab, we want to be able to demonstrate that it actually has meaning for the people in their daily lives, and that when the measure gets better, when you test them, that it reflects something that's actually happening in their life. So many years ago, this is the kind of aha moment that I had when I started reading about the toolbox and realized that there was this very broad developmental range that was being addressed from age 3 to age 89. And I knew that many of our individuals that we study with intellectual disabilities are older, but have mental ages that are lower. And so, excuse me, knowing that it could capture this broad range was an advantage. I also started reading about the toolbox in the monographs papers that came out many years back, and saw some of these graphs that showed these very nice tight error bars around different ages across development. And I said, that could really be something that could be sensitive not only to developmental changes in people who have disabilities, but also within treatment studies, could they also be equally sensitive? I'm going to just skip by this because you've heard a lot about the toolbox battery, but this is just a depiction that we use when we do the testing with our participants so that they can see what to expect in their assessment day. One of the things that we discovered in using the toolbox, many of the things that we discovered were sort of gaps in the capacity of the toolbox to do a really good job of measuring cognition in certain subgroups. And we found that in some people with intellectual disability, actually a substantial number, on a test such as pattern comparison, we were getting some invalid pattern responding, where it seemed like the individuals were doing the test properly, but when we actually paid close attention, they were actually just kind of randomly choosing the left or right button. And we realized we needed to come up with something different. So Aaron, who's here in the audience, Aaron Cott, sorry for the old picture. You gotta give me a new picture, I guess. We worked extensively with Aaron to develop a new test that was going to be less susceptible to this problem. So in this particular processing speed test, the individual just needs to match the image that they see in the top with one of the 4 at the bottom. So instead of having only 2 choices, now there's 4 choices. So less chance responding and less susceptibility to pattern responding. So that was just one of the advances that we had during working on this project. We also spent a lot of time coming up with a administrator's manual that's specifically designed for people who are testing patients or individuals with intellectual disabilities. They're very challenging to assess for a variety of reasons, and they also need more support than most people who are typically developing. So we developed some accommodations and some guidelines around what kinds of rewards can be given for which tests, how many prompts can be allowed, basically essentially making some just tough decisions about how to keep things consistent across different sites. And I should mention this is a multi-center project. So we wanted to have a document basically to help people know how to give the test consistently. We use an administration form where We have the examiners record whether they determine the test to be valid or not, and if it's not, the reasons why. They can take notes. And then when we query the toolbox data, we also query data from the administration form, and we can then kind of screen out tests or administrations that the examiner felt was invalid, so that we don't mistakenly use that in our analyses. This is just kind of a quick view of some of the reinforcement guidelines that we developed that are dependent on each test. These data are a little bit old now, but I wanted to kind of reflect all the work that we've been doing over the years. This was the first kind of big paper that came out of our project by my graduate student, Rebecca Shields. And you can see that we studied over 200 individuals with intellectual disabilities. We have been focusing on Down syndrome and Fragile X syndrome because they have the biggest translational research programs, basically in the United States and probably around the world, in terms of taking targeted treatments from animal models to humans. So we focused on that, and then we included a comparison group of people with all kinds of other intellectual disabilities. This is a really useful slide if you're thinking about using the cognition battery in people with intellectual disabilities. So what you see here is mental age here across the top as determined by the Stanford-Binet IQ test. And then each of the, that doesn't really point very well. I don't know. Yeah. Each of the toolbox tests are listed on the left. And then this is just showing you what proportion of each age group was able to do the test and yielded a valid score. And you can see how the battery really does well with a mental age anywhere from about 5.0 years and up, and then a little bit spotty at mental age of 4, and then it drops off more significantly for the fluid reasoning tests and a mental age of 3 and below, although it does quite well still with crystallized cognition, as you can see with picture vocabulary and oral reading at the bottom. We've done a lot of work looking at test-retest reliability, for example, over a 1-month period, and also trying to determine whether there are any practice effects. And you can see these ICCs are generally pretty good and in line with what you see using other tests in this kind of population. The only exception really was picture sequence memory. That's the episodic memory test. So even when we use the same, this is a weird pointer. Even when we use the same version at both time points, we found that not to be as reliable as the other measures, but the composites did quite well. In terms of known groups validity, so I was mentioning, do you see, can you find the kind of deficits that you'd expect to see in a population? And we noted that the Down syndrome group and the Fragile X group really had very prominent executive function weaknesses, which is known in the literature. So we were happy to see that it was picking up on some phenotypes that we know about in intellectual disabilities. This was also done by Rebecca. This is one of my favorite graphs from all of our work. It shows the association between the cognition composite score, the total composite score on the toolbox, against the Stanford-Binet full-scale IQ. And aside from the fact that there's a strong correlation, which you can see here, the regression lines really fall kind of where they ought to be in terms of not being skewed too high or too low. So a 25 on one test is relatively equivalent to a 25 on another test, and on up through kind of the lower average range. So some reassuring kind of cross validity with another measure. Rebecca's, I have like a minute or two. Yeah. Okay. I'll try to go faster. Rebecca's done some longitudinal modeling to look at sensitivity of change over time, and has shown some really interesting kind of differences across syndromes and across cognition test components. And I'd urge you to look at this paper if you're interested in looking at development with the toolbox. This is just an example of kind of at different age points, which tests are detecting significant growth in cognition in individuals with Down syndrome. So you can see more growth centered at around age 10 and age 16, and then less growth and more plateauing later on in development. Andy Dikopoulos, who's here in the room, has been working with me. Well, he's done all the work. We've been working and talking a lot together about how to look at change in toolbox cognition along with development in daily life as measured by the Vineland Adaptive Behavior Scales. And Andy has done some fantastic dual latent change modeling that shows that some components of the NIH Toolbox cognition, when they are moving and there are gains in these individuals, we also see gains in some aspects of adaptive behavior, especially in daily living skills. Andy has a poster, so I'd encourage you to come and take a look at his poster and talk to him about his modeling if you're so inclined to learn about these sophisticated statistics. Dr. Barry Kravis also has a poster looking at sensitivity to change of the toolbox within a clinical trial that was headed by Tetra Pharmaceuticals, looking at a phosphodiesterase inhibitor. And I won't spend too much time because I think I'm running out, but the basic result or important thing to tell you is that the toolbox crystallized cognition was sensitive to the treatment benefits of this targeted treatment for Fragile X syndrome. These are some of the other trials that are either ongoing or planned that will be or are using the toolbox, either as a primary or a key secondary endpoint, mostly on Fragile X syndrome. But at the bottom there, I note the one initiative by ALS Pharmaceuticals that's looking at a endocannabinoid receptor modulator in Down syndrome. So we're real excited to see that group also picking up this as an outcome measure as well. These are all my collaborators. It's, like I said, a multi-center study. So we've had 10 years of work, and so we've had different staff members coming and going, but lots and lots of contributions across mostly UC Davis, Rush, led by Liz Berry Kravis, University of Denver or Regis with Karen Riley and Janine Coleman, and Craig Erickson at Cincinnati, and then all the help and support from the Toolbox team at Northwestern. So I will stop there, and thank you.
And I will have our speakers come up to this table for the Q&A session. If you have any questions for them, the microphone is up front. It's better for people online, potentially. I can try to repeat things if they don't pick up. Yeah.
Thank you for all the talks. I have a question. I guess I'm wondering if you guys can kind of synthesize across the talks. There were a couple different flavors of results in terms of correlations with IQ. Wondering if you guys want to talk about that. You two are pitted against each other.
Which test?
So we use a combination of Wexler scales, and I know you all do that Stanford Binet scoring. So I think that might be part of it, is that the Hessl group uses a slightly different scoring on the Stanford that you could expand if you're not familiar with it. But I think that might be something. I think also go ahead.
Well, yeah, floor effects are a problem in lots of studies in intellectual disability. So I'm sure that we've rectified that with the scoring that we use. But I think we still, even when we use the standard score, that's not the deviation adjusted one, I still think we get pretty decent correlations with the Toolbox.
Mhm.
So yeah, I really don't know how to explain it. I think, it's really oftentimes you just have to go down and look at the items that people are administered and see how much overlap there is in the constructs that are being tested. But I don't know how else to explain.
Right. I know another issue that we ran into with our population was the number one dropout reason was attention. So in addition to either not passing, like the reason they weren't passing the practice was because they could not attend to the class. So some, like the flanker and the DCCS, definitely have clearly like measuring in part. So it might be related to that, where they're not, even throughout testing, we had to redirect them a number of times because they would be trying to talk to the examiner and things like that. So it might be related to that.
But I'm sorry, just if I could there be anything unique about Williams syndrome in terms of their visual spatial craziness that, I mean, not craziness, but just like they have so much trouble with it. Like, is there something just unique about that that would make the correlation more difficult to detect?
I don't think so, because the tasks we use don't tie to right? But it's the DCCS and the flanker. Right. Mm-hmm. Well, right. So their main thing is that they're split in the verbal and the nonverbal. Like their verbal scores are high on the test, whereas the nonverbal. So that might.
Because I mean, Toolbox doesn't. Sorry. Toolbox doesn't really have visual spatial processing as a, whereas the MDI does.
Right.
So that could be a big.
I wondered a bit, do you think is there enough variability in the raw scores when you're looking at these sort of floor effects that potentially like renorming for these types of clinical populations would have utility?
So we didn't renorm, but we leveraged the normative data that the publishers gave us access to, for example, from the Stanford Binet, and we basically essentially disregarded their Windsorizing, they're cutting off at a certain point, and we just calculate the number of standard deviations, essentially, of deviation from average using the raw scores. And so that was really effective. It wasn't renorming, but it was a way to get something that gives us more sensitivity to differences.
So related to the toolbox, I think potentially my understanding is that there's no reason it necessarily needs to be Windsorized at 54.
Yes.
Yes.
Thanks for reminding me. So on that point, because our population, as you can see, their score is nearly 2 standard deviations below. So we actually calculated if, for example, if they don't pass the practice test or they got 0, so we have to calculate the score rather than, use the same score. Yeah, not Windsorized.
So from those who've used it longitudinally, I know that some of the scores are changing with the version 3 to make it, I think, more amenable to change over time. But what do we think needs to happen now to make the measure ready for it being used as an endpoint or, sensitive to change in these kinds of trials?
Since I think about this all the time, I guess I'll try to answer. So we've done a lot of the work, I would say, already that the FDA is interested in. There are some gaps, though, that are super important to fill, and Dr. Kat is addressing one of them, which is clinically meaningful change. So when a single patient, has an improvement, we don't know whether to interpret that as a clinically meaningful improvement or not. And so we need to do some analyses that will help us give at least an estimate with a confidence interval around it, of how many points of gain on each component is considered clinically meaningful. So I think that's really important. I think the work that Andy's doing, looking at associations with, what's happening in their daily life is important. And I think just more work to educate the decision makers about, what the strengths and limitations are of the toolbox. And just seeing it done in more trials, basically, and how it performs. Liz, do you want to add to that? Do you want to get up to the microphone?
From being at FDA meetings. So it seems like the thing they want is to really be able to see this validation data. Because we had a long discussion about it when we first went in with Tetra, and they seem to want the data, in addition to be published in the literature, to be something they can see in an FDA compliant database, like through a sponsor. I think Tetra is going to help with that because we're rerunning all of David's validation analyses in the Tetra trial. Granted, it's not the ideal population because it's the placebo group, or it's a group before they actually start treatment, but it's kind of what they're going to have to work with. So I think it's just going to take time for FDA to accept it, but I don't know if anyone's from FDA. But I was really hoping FDA would attend this meeting because there's so much work that's been done on this. And when we first went in, it was almost like they hadn't heard of it. And it was like, David was at the meeting too. It was like a whole new concept. And I think it's really important for them to start looking at this.
Maybe.
All right, to repeat that question for the online people, are there any other sort of syndromes that you would like to sort of repeat these studies on in the future?
I think for me and a lot of us, it depends a lot on the success of Baby Toolbox. You can see from the data that I showed that there's a drop off in the utility of the regular toolbox at a certain developmental level. And we need that gap to be filled with the Baby Toolbox to enable us to include these other syndromes that are more severely affected than people with Down syndrome. Not that people with Fragile X and Down syndrome are not sometimes severely affected, but there are syndromes where the delay is even more significant. Or people who have a really common syndrome like Down syndrome, or even just idiopathic intellectual disability, who just happen to be kind of below the level of the regular toolbox. So we really, really need that Baby Toolbox. And then I think we'll be able to study more broadly these other conditions.
What you said, because, especially in rare disease, a lot of times children were born with those conditions. So you want really have interventions as early as possible. But when you don't have a valid tool to understand the development delay or cognitive impairment, you can't really, do much about it. So advancement in Baby Toolbox and keep advancing the NIH Toolbox is super important. I think from the study we conduct in the pharmaceutical industry, I think there is a lot of utilities in using sort of a common currency such as NIH Toolbox and using different disease and compare the score to understand, and in this rare disease population or even in general, how to compare impairment.
I will be the third to echo what they already said.
Mhm.
Yeah, and relatedly, a lot of the work that we do in the neurodevelopmental and behavioral phenotyping service here on campus, and I say we, but it's not we anymore, but is with nonverbal or pre-verbal populations. And so again, the baby toolbox and those eye tracking measures, if they really can work in these populations, could be potentially very valuable.
Can I answer this question too? I want to answer this question too. I think one of the places where I want to see more populations that we're willing to test is some of the examples where we have primarily motor disorders and we've neglected cognition for maybe too long, where it's more of a subtle deficit. And so we heard a little of that, and I appreciate that, but I think there's a lot of disorders where we might not think of them as affecting cognition. And it's time that we say this is an important thing for safety purposes. It's an important thing because we're not recognizing subtle deficits. And if we can do a better job with that, if we stop thinking about neurodevelopment and being only about those that are primarily in cognition, we might realize some things that we've neglected for too long.
Or those disorders that have both motor and cognitive impairments, and the cognitive assessment is not accurate because of some of the motor skills. I think there's a place for a toolbox here as well. So we have a bunch of those disorders. But I wanted to ask you, it's interesting, this percentage of patients that falls in the quote severe range, which is basically below normal. As time goes on. And we've noticed this actually in our long-term follow-up of our Niemann-Pick patients as well. And they have disease and we get them on treatment at a certain point, and then we kind of freeze the disease, but they're young. And so we're not really testing executive function. So when they have an emerging problem with executive function or something, we don't really know whether that is the emergence of the damage that was done before or whether that is a new deficit. Do you have any thoughts on that in galactosemia?
I think I don't have a definite answer, but I'm thinking, because galactosemia, galactitol is, produced in those children, normal people don't produce galactitol. So even though they have galactose-restricted diet, the galactitol still accumulates in the body. So we assume that the damage has already happened in a prenatal period of time, that potentially not going to be recover from it. But because of the body still produce galactose, the damage is still going on. So using agents that we can hopefully prevent further decline of cognitive function will be beneficial. But how much we can do that is really also depending on how good of measurement we can see where is the decline. Is there the placebo population? How would that go and compared to the active treatment? So I think there is a lot of unknown for rare disease because it's just not being well studied.
All right, that wraps up this. Thank you so much to our speakers.